Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting brain imaging case of the day. So as always, I want to explicitly state that all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. So here's the history on this case. This is a patient who had had a very recent left pterional craniotomy and resection of a left temporal lobe GBM, or glioblastoma. So I've got two images for you to look at. The image on the left was the preoperative MRI, and I'm showing you an axial GRE sequence through the posterior fossa. And then the image on the right is the postoperative MRI, and that's showing you an axial susceptibility weighted image through the posterior fossa. So again, image on the left was the pre-op, image on the right is the immediate post-op, and again, this patient had a left pterional craniotomy. So take a look at the images, try to piece this together. Okay, so what are the findings? What's the name of the sign for this radiologic finding? And what's the diagnosis here? Okay, let's first start by looking at that pre-op image. And this again was a GRE in the axial plane through the posterior fossa. And let's cut to the chase here. This is normal. There's nothing wrong with the cerebellum, the posterior fossa structures seen on this image. Okay, so now let's look at this post-op image. Now this is a susceptibility weighted image, oftentimes sort of referred to as GRE on steroids. It's just a very sensitive sequence for looking for blood products. And what we see here is a band-like area or band-like areas of signal abnormality in the right lateral cerebellum. You can see denoted here by the yellow arrows. And this is blooming artifact. This is gradient susceptibility with blooming artifact due to blood products. So we have sort of this strided pattern of gradient susceptibility, and that's been referred to as the zebra sign because it sort of looks like the striped coat of a zebra, the black and white coat here. So what's the diagnosis in this patient who'd had a recent left pterional craniotomy and GBM resection? So this is a case of remote cerebellar hemorrhage, and this is a cerebellar bleed that is spatially removed from the surgical site. This can involve the subarachnoid space, or it can involve the parenchyma. If it involves the parenchyma, it's usually superficial, but this is geographically removed from where they did surgery. In this case, the surgery was contralateral and supratentorial. This is a posterior fossa bleed. So this is a rare complication seen in less than 1% of patients who have a supratentorial craniotomy, sometimes even seen in the setting of spine surgery. Estimated anywhere between 0.5% and 0.8% of cases. But this is about a third of the time going to be contralateral, about a third of the time it may be bilateral, and about 20% of the time may be ipsilateral to the site of surgery. Sometimes it can involve the cerebellar vermis, and rarely do we see this supratentorially. It's usually infratentorial posterior fossa. And this is most commonly seen in the setting of a pterional craniotomy or some sort of a craniotomy for an aneurysm clipping, or in the setting of a temporal lobectomy, but you can see it with other surgical procedures. What seems to be a common theme is there's a large CSF volume loss, either through shunting or through incidental loss of CSF through leaks at the ventricles, leaks at the cisterns, or even in the thecal sac. So what is thought to happen, although it's not known for certain, is that there's this transient CSF hypovolemia because either there's overshunting or there's a leak of CSF and it causes a rapid drop in CSF volume, and that ends up leading to venous injury and venous infarction. So nobody knows for certain, but that's sort of the presumed hypothesis here. And it can have a wide-ranging clinical spectrum. These patients may be completely asymptomatic. This may be a purely incidental finding on the postoperative scan, or they can have catastrophic hemorrhages. Most of the time, it's sort of on the benign end of the spectrum, but certainly there can be associated morbidity and mortality associated with these hemorrhages. On occasion, they'll even have to do decompressive craniectomies in order to evacuate these posterior fossa hematomas. So here's a nice paper. It's a recent paper in World Neurosurgery talking about remote cerebellar hemorrhage following surgery for supratentorial lesions. Again, this focuses mainly on the supratentorial disease. Just know that that's the most common etiology is supratentorial craniotomy, but you can also see it in the setting of spine surgery. So worth taking a look at to be familiar with this, this sort of unexpected rare complication. Okay, so to wrap this up, this was a case of remote cerebellar hemorrhage. And the key imaging features here are that you'll have a patient with new cerebellar hemorrhage, which may be subarachnoid, it may be parenchymal, but it typically follows supratentorial or less commonly spine surgery, usually in the form of a craniotomy for aneurysm clipping or a lobectomy. So we're looking for blood in the cerebellum or along the cerebellum. On MRI, it will be variable in signal intensity, sort of depending on the age of blood product and how quickly the patient was imaged after surgery. But it is a nice example of the power of using GRE or susceptibility weighted imaging to look for blood products. These are our sensitive sequences, especially SWI, and something that we routinely do for all of our postoperative patients here. But you'll see that gradient susceptibility with blooming artifact on GRE and SWI. Now on CT in the acute phase, you'll see hyperdense blood in or along the cerebellum. So a pitfall to know here, while this is oftentimes self-limited and asymptomatic, death or significant disability have been reported in cases in a minority. And keep in mind that just like any time you have a cerebellar hematoma, the posterior fossa is a relatively small and unforgiving space, so these patients may require surgical evacuation of the cerebellar hemorrhage. So keep an eye out for that mass effect. Keep an eye out for that herniation that can potentially compound this important diagnosis to know about. So as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at @NAKuntz, and I would invite you to check out our complete collection of Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.